Hey, welcome and good afternoon to everyone. My name is Tara Smith, and I'm the Executive Director of Central Hall Commons, a multi-generational community center in Piscataquis County. Central Hall Commons' mission is to nurture a welcoming, inclusive, healthy, rural community culture by engaging people and organizations in the Maine Highlands region in connecting, celebrating, and learning together. We envision a community where all voices are heard and people of all generations feel safe, valued, included, and cared about. I'm honored and inspired to introduce this afternoon's common conversation, The Care We Deserve. Thank you to everyone that came together to organize this program. I'll now pass it on to Shauna Collins to introduce our speakers. And thank you for joining us today. I invite you all to sit back, get comfortable, and enjoy the conversation.
Thank you, Tara. So today we have three speakers. Abby is the Director of Education and Community Engagement at Mabel Wadsworth Center. She coordinates the center's advocacy and education programs focused on reducing abortion stigma, educating about the intersection of LGBTQ rights and reproductive freedom, and advocating for the rights of all pregnant people. Her pronouns are she, her, and hers. Aspen is the client and community advocate at Mabel Wadsworth Center. In this role, they predominantly work with trans clients in helping to overcome barriers to accessing gender-affirming care, which means a lot of time spent on hold with the insurance companies. As someone whose gender and sexuality fall under the queer umbrella, the importance of safe and affirming healthcare access is an issue near and dear to their heart. In their free time, Aspen enjoys embroidering, gardening, and fighting the system. Their pronouns are they, them, and theirs. Kate Vaughn is a white, queer, and genderqueer birth worker, abortion doula, and childbirth educator who grounds her approach to caring for pregnant people in community care and becoming informed about one's rights as a patient and birthing person. Thank you all for joining us and agreeing to present to our community on these very important topics.
Thank you so much. I'm gonna start. I'm really happy to be here with everyone this afternoon and very excited to talk about the care we deserve, and especially to be here with the Central Hall Commons, as well as Kate and Aspen, who I always love to be in conversation with. I'm going to take a few minutes to just talk about Mabel Wadsworth Center and then kind of talk about what I'll be speaking on this evening. So Mabel Wadsworth Center is based in Bangor. We are, for folks familiar with the Bangor area, we're across from the Humane Society in this business or complex called Evergreen Woods. So not too far from like the mall area of Bangor. We provide sexual and reproductive health care, and we've been really a essential part of our community since 1984. We provide a wide range of services, including abortion care, birth control, STI testing and treatment, gender-affirming hormone therapy, prenatal care. We recently added primary care as a service. We also offer mental health counseling and vasectomies. So you can see our services have expanded throughout the years. We have reduced cost care for folks of low income and accept all private and public insurance. So Maine Care, and then most private insurances will be accepted at our clinic. And we serve folks from all over northern and eastern Maine. People tend to travel quite a distance to seek our services, as many services in Bangor, people travel from a distance to seek a lot of care in our community. So we're really happy to be there. We also really value being a part of our community. So of course, as probably all of you have experienced, that this past year in the pandemic has shifted how we all engage with each other in our communities. And that has been a learning process for us. because we were really used to being at community events in person with folks, and learning how to still engage through these virtual settings has been a new experience for us. So Aspen's going to be speaking after me. So if I've forgotten some of our work, I'm sure that they can add on about us. So today I'm going to be focusing on the abortion care work that we do, as well as sexual health. I've been working at Mabel Wadsworth Center for 10 years, and I've mostly done community engagement work, but I've also had the privilege of working as a clinical assistant and supported hundreds of people through their abortion experience. And a really big part of my work that I am really passionate about is working to normalize abortion, because it is normal. 1 in 4 of us will have an abortion, and it's a really normal part of our reproductive lives. One of an activist that I follow, Renee Bracy Sherman, says everyone loves someone who's had an abortion, and we just might not know it because it's not always talked about. But I think this is really important to remember as we have this conversation, because it's very likely that folks that are part of the conversation tonight have had abortions. When we are having more of an abortion debate, it's likely that somebody you're speaking with has had an abortion, because it is so common. It's just that we haven't given much space to talk about it in our community. So that's the work I focus on, is really talking openly and honestly about abortion, and giving space for a wide range of experiences. Similar to birth, people have a wide range of experience with their abortion, and while most people don't regret having their abortion, the experience can be anywhere from feeling empowered to feeling like it was a traumatic experience, and really allowing space to have that wide conversation about what our experiences are. And then also wanting to work on taking back the narrative. So we're not talking about it from a place of shame. When we at Mabel Wadsworth Center talk about our abortion work, we proudly state that we're the local abortion provider, and we also want to educate the community that we provide a wide range of additional services. So we don't want to hide from the fact that we're an abortion provider, even when we're trying to promote services like primary care or mental health counseling. And then we also, like, the other piece of the work that I'm going to be talking about is just generally the importance of talking openly about sex and sexual health. And some of the work that we do around that includes, we have a story sharing project that started as really centering around abortion experiences, and now we've expanded it to include a wide range of sexual and reproductive health care experiences, because so many of our experiences are stigmatized and not talked about. And we wanted to offer space, and we occasionally offer story sharing workshops in addition. And Aspen has a podcast called Reproductive Left, where we tackle topics on sexual and reproductive health, which also includes a wide range of topics. Like the first series that they just did was on gender, but then we just had a great conversation about perhaps an upcoming podcast being all about lubricant. So really trying to open up the conversation about sex and sexual health in our communities. And I'm excited to be here tonight to continue that kind of dialogue. So I'll pass it on to Aspen and look forward to continuing to talk.
I don't think you missed anything about our services. I think you caught everything. And yeah, I am honestly very excited to do the lube episode of Reproductive Left, because as Abby knows, I could probably talk about that for hours. But you'll have to wait, because that's a conversation for a different day. My focus today is more talking about accessing gender affirming care. And oftentimes, you know, when I just say the phrase gender affirming care, there's often the question of what does that mean? And for me, and for a lot of people, it can mean a lot of different things. You know, most often we think about, so gender affirming care typically applies to trans folks, transgender folks, you know, accessing care that affirms their gender, that, you know, feels right for them. You know, most often we think about things with like accessing hormones or accessing gender affirming surgeries. And those can be really important parts of care. But for me, all care should be gender affirming care. And I know that that's a thing that we strive for at Mabel Wadsworth Center. You know, when you go for a primary care visit, like your primary care provider should be nice to you and should use the right name for you and use the right language for you and just, you know, not be a jerk. And I want that to be true for everyone, you know, regardless of what your gender is. And of course, for trans people, that's a thing that we run into a lot where, you know, a lot of medical providers just don't have a lot of knowledge about trans people. So even if the care that someone needs isn't really specific to or even about them being trans, you know, sometimes medical providers can make it a little bit weird. And so that's one of the things that I really like with getting to have conversations like this. You know, while this isn't targeted towards medical providers, it's definitely targeted towards like getting everyone thinking about how like, yeah, you know, trans people are just people. And I feel like most people who are here are just going to be like, duh, Aspen, we know that. But, you know, on the, you know, when it comes to medical providers, something that comes up in conversations in the trans community a lot is broken arm syndrome, which is like if you're a trans person, let's say you break your arm, you go to the ER, and that ER visit, you know, the doctor is just asking about your gender. And it's like, that doesn't really matter. I'd like a cast, please. And I think that, you know, again, even people who aren't in the medical field, we all have a role that we can help fill with really changing the culture around that. So that, you know, if we break our arm, we can just go get a cast and have it be a big deal. And that's, you know, like I said, one of the things that we really strive for at Mabel's, that whether it's hormone therapy or whether it's prenatal care, you know, that all of the care we do is gender affirming and, you know, really breaking down the stigma around accessing it. And like Abby was talking about with abortion care, you know, some of that stigma just comes from a place that there's this almost shroud of mystery around it. And I feel like that's very true of, you know, transness, just being trans, and even more like trans specific healthcare. For a lot of people, there's this kind of like shroud of mystery around, you know, what's a trans person, and, you know, realizing that like, oh, this is just a normal thing, just like with abortion is a normal thing, kind of helps, does a lot to really do away with stigma. And with that, I'm going to turn it over to Kate.
Thanks, Aspen. Can folks hear me okay? Great. So yeah, I'm here today to really talk about like a community-based model of childbirth education and birth support for pregnant folks. And I love being here with Abby and Aspen because it's really doing abortion work that led me to be interested in birth work, because I started to really think and feel deeply about the ways our society is not set up to care for people who are pregnant, whether they're seeking to end those pregnancies or continue them and give birth and raise families. And it started to make me really mad. So it sent me on this journey to become a doula, or a birth companion, and more recently to create a childbirth education sort of project, I guess, that is meant to focus on what our rights are as birthing people, and to support people. You know, the goal of childbirth education for me is to co-create spaces with learners for healing, sharing knowledge, and moving into our personal and collective power so that everyone can exercise their rights and honor their truths during pregnancy, birth, and the postpartum period. And really, you know, I think what's important to me in thinking about this in terms of Piscataquis County and the Dover-Foxcroft area and rural spaces in our state is that those places in Maine are often talked about as being under-resourced, right? And while it's true, we need more of our state resources going into our rural communities, it's also true that we as individuals, as people in our communities, we actually have a lot of resources and power that we can share with one another. And I think over the past year of the pandemic, we have seen the sort of projects and mutual aid efforts and leaning on one another that people are capable of doing. And so while I'm interested in changing the medical institutions and how, you know, the sort of medicalizing and pathologizing of birth, I'm also interested in like, what is our people power in a very grassroots way to improve outcomes for all of us? Particularly, my work tries to center people who are low income, so poor folks and birthing people who have histories of substance use, drug use, or are currently in recovery and treatment. So, you know, we're going to talk a lot about, I think, stigma and barriers today. And those are really important for us to consider. But we called this The Care We Deserve because I think we're also really interested in talking about where are we seeing glimpses of the care we deserve, and like, how can we make that a bigger and bigger reality? How can we scale that up? So that's what I'm here to talk about today. And I think that's enough of a sort of introduction. So I'm going to hand it back to Abby. Do you want to start us with the first sort of question?
Yeah, I'm happy to do that. What are the barriers to the type of care that each of us are bringing to the table tonight? And Aspen, do you want to start?
I don't mind. So one of the biggest barriers to accessing care for like gender affirming care, especially if we do get more specific with like gender affirming hormone therapy or gender affirming surgeries, and this is going to be true for all of the things today, obviously like travel, because like rural Maine, and also even if you live in Bangor, like we could have a better public transit system. So like travel is a huge thing, and like cost is a huge thing. And obviously like that's true for all of the topics today. One thing that comes up that's like pretty kind of specific to gender affirming care, or just really any care that trans people are trying to access, are specific barriers around insurance. You know, insurance was barely designed to work for people who are cis. For those who don't know, cis people are just, it's like people who aren't trans, is the really simple way to explain it. So, you know, like if you're someone who's a cis person, like you probably are like, yeah, my insurance barely wants to do things for me. It's an even worse setup for people who are trans. You know, their systems just don't basically recognize that we exist. So something that trans people run into a lot is they can have like the most comprehensive insurance coverage, like the shiniest insurance plan in the land, and still run into getting like coverage denials for things just because they're trans, even though that's like super duper illegal, because, you know, insurance companies feel they're above the law. This is why my bio is about how I get to wait on hold with insurance companies a lot, because I get to call them to bully them. But, you know, they do that. And then if we're also being realistic about trans people and insurance, most trans people do not have the shiniest, nicest insurance plan in all the land. You know, people who are members of the trans community are more likely to be in poverty than the general population, just because of like discrimination. You know, if you're trying to get a job and the employer at that job is transphobic, like you're probably not going to get the job if you're trans, or you might get hired and then get harassed a lot, which again, super illegal, but you know, people break laws sometimes, if you can believe it. And yeah, so those, you know, that's an element where it's like cost is a barrier, but there's another layer to it for trans people. And then another thing with it is just, I know I mentioned that there's an issue with like medical providers just like not having knowledge about trans people and not knowing how to work with them, which sometimes manifests as like, oh, you're a trans person, you break your arm, you go to the ER, and it just gets real weird. But sometimes that manifests as like, you're a trans person and you're like, hey, I want to get on hormones. And you try to go to your primary care provider, who's more than qualified to do that. And either they refuse to because they are transphobic, or they're like, oh, I don't know how to do that. And instead of, you know, learning how to do that, we'll just be like, oh, we'll refer you to this place that's like 50 miles away, which is usually us.
I'll let Kate go next, but I did want to just say, like, if anybody wants to also respond to this question in the chat box or in the comments on Facebook, we'd love to hear what barriers either you've faced or folks that you know have been facing, and then I'll let Kate take over.
Yeah, so I mean, very similarly, part of what I think ties all the types of care that we're talking about tonight together, one is that all these types of care come with stigma and judgment. And I think it's important to know that stigma, to just say that like stigma isn't just, oh, this person made me feel judged and that felt bad personally. Stigma is what is one of the forces shaping our policies and protocols and the education that medical providers receive, that doulas receive, etc. It's both interpersonal, it's social, and it's also really structural, right? So there's sometimes a lack of choice of provider in some communities, right? So if someone's not a good fit for you as your OBGYN or something, but they're the game in town, that's who is going to be a part of your pregnancy and birth. And that can be really difficult to have to go without choice. Particularly if you're someone who is low income, if you are someone who's pregnant, who is a smoker, who uses drugs, who maybe struggles with, you know, being able to get nutritious food on a regular basis or manage your stress and your blood pressure. Like those are all things that you want a really caring provider for, right? You want someone who's going to work with you and meet you where you're at. And if you have limited choices, that might not be available to you. And so that's important to think about in terms of healthy pregnancy. If people are living in poverty and struggling with nutrition, that affects their ability to have a healthy pregnancy. And instead of, sometimes providers will, you know, they're working on a really individual level. So they can think about, oh, you as an individual need to eat more iron and protein and all these things. But at a systems level, we can say, what access does this person really have to all those things on a regular basis, right? We've seen rates of infants born with some type of substance exposure rising for years. And over the pandemic, some things have gotten, that number has continued to rise. And also we're seeing a rise in children being placed in Maine's foster care system. And those rates are quite high in Piscataquis County. So, you know, we're looking at Piscataquis has a rate of 11.8 per 1,000 children. And that is higher than most other counties in Maine. So when I think about the care we deserve, I have to really think about if a lot of folks who are giving birth are low income and a lot of folks are using some kind of substance or in some kind of treatment for substance use, how does our provision of care need to change to meet people where they're at so they can have the healthiest pregnancies possible? And one of the barriers that we have is that medical providers are mandated reporters. They're required to report things. And we have laws in Maine that if a child is born with substance exposure of any kind, they're automatically reported to the Department of Health and Human Services, and an investigation begins to determine if that parent is fit to bring their child home. And so I just want to say that when we have mandated reporting as part of healthcare provision, for people who are trying to navigate a complex life and still have the healthiest pregnancy they can be and be the best parent they can be, mandated reporting can discourage some people from getting prenatal care at all, or it can discourage them from telling the full truth about what their needs are to a provider. So that's just a built into the system that we're all in. We tend to think about pregnancy care and support as very individualized. And I guess I'm trying to take a community-based approach that allows us to think about all the ways that we might offer support and real care instead of punishment and judgment. And once someone is pregnant, it's almost like automatically society just says, okay, your body and your choices are up for public discussion and control. And that's whether you end a pregnancy or you continue it. And that's really the thing that I want to remove. I think when we remove shame, when we remove judgment, and we take a sort of harm reduction approach of like meeting someone where they're at and seeing what's possible, we will have much, much better outcomes for newborns and for birthing people. So those are some of the sort of barriers to the care we deserve. And I think the other piece, the last thing I'll say about this is just, I think it's really important to acknowledge that obstetrics in this country, gynecology, these are professions and spheres of study that are really deeply rooted in rape culture and racial domination and like enslavement, right? So the things that we know, the father so-called of gynecology, Dr. Marion Sims, you know, he discovered a lot about obstetrics and gynecology from forced experimentation on enslaved Black women, right? Who are not usually talked about in the history of this, and also familial bonds among Indigenous people and Africans and enslaved Black Americans. That's really how our country is very rooted in this disrespect for some people's familial bonds. For some people, it's almost impossible to be viewed by larger society as a fit parent, no matter what you do. And so when I think about our present day family policing system, which is called the child welfare system, but it's really a family policing system, I really think of how that is there's a direct line from enslavement and genocide of Native people and the breaking down of families to what we have in the foster care system today. There's a real direct line between the experimentation that Dr. Sims performed on enslaved Black women to the way that rape culture shows up when people give birth in this country today in hospitals all over the place. So a lot of my work is trying to talk about what consent really means when someone's giving birth and how to prepare and get support so they can really have birth on their terms. But it just feels important to acknowledge that history because it's really real and people are living it like every day. I think it's you, Abby.
Thanks, Kate. So I'll start with talking just a little bit about the availability of abortion in Maine, which is a big barrier to care because it's not super accessible. So there are 3 publicly available abortion care providers, which includes Mabel Wadsworth Center. We're based in Bangor. Maine Family Planning, that they have a clinic in Augusta that does the in-clinic procedure. And then they have, I think, and Kate can correct me because she used to work there, 18 clinics across the state. And that's mostly in like north of Portland
Yeah, there's one in Dexter right over the county line.
And yeah, thank you. And then there's Planned Parenthood based in Portland, and I think they have a couple clinics also in Southern Maine. And but still cost, transportation, getting time off work. So most of the clinics have certain days that they offer abortion care. So you have to get a really specific day off of work to get to the clinic. So time off work and childcare. And then one of the biggest things that our clients have named is keeping it a secret from somebody close to them has been a huge challenge in getting to the clinic. And I think you could also, if we look at rates of domestic violence in our state, if you're keeping this a secret from somebody that you're experiencing abuse from, that creates quite an additional barrier to seeking care. And all of this again is just like what Kate was saying, based in stigma. So like the barriers, like the reason it's not accessible in all of our communities as it should be, is because we have decided not to fund it and not to support it, because it has been a marginalized service, even though it is one of the safest and most common procedures done in the United States. But then the stigma also impacts our day-to-day lives, right? Like you need a ride to get to the clinic, but you don't know anybody that you are certain will keep this confidential for you. You need to get time off work, but you can't tell your employer why. You need your mom to watch your kid or and you have to make up a reason why, because they have bans on telehealth so that they can't increase access by using telemedicine in rural communities. So, and then additionally, the major one of the cost of the abortion procedure itself, that most states don't cover abortion in their state-funded health insurance. And we have the Hyde Amendment that prevents federal funding. And like,
Abby,
yeah.
can I jump in here? I just see an opportunity to kind of circle back to the story sharing project.
Yeah.
And ask if this includes how to speak to, say, a partner about an STI, or family members about identity, or having those kind of difficult conversations, because it seems like a really good opportunity to address some of that and break down some of the stigma.
Yeah, that is definitely a part of the work that we're really engaged in. I think the most of that right now is happening with, well, Aspen leads a lot of like sexuality education classes, and then also our clinicians work with people to support them in those conversations, right? Like, so if you come to us and you find out that you have contracted an STI, we don't just like give you that news and are like, good luck. We have a conversation about like, so this is what that means for you, for your health. And this is how tips on how to have an honest conversation with your partner about it, or partners about it. Because it's super normal, right? 1 in 5 people will have an STI. And most of them like don't have huge implications on our lives or our sex lives, as long as we're talking about it. A lot of them are very easily treated. People live really, even with some STDs are not treatable, right? You live the rest of your life with it, but people are having very healthy, fulfilling sex lives with herpes, with HIV, right? And it's just that we have to be talking about it and supporting folks in how to have those conversations with the people in our lives. and really breaking down a lot of misinformation about it. So like the first thing people will be like mistrusting you or something, but you could have gotten an STD a long time ago and then it's showing up currently. So really just like breaking down the information and giving them the tools to answer their questions is an important part of that work. There's a story of one of our providers that met with somebody like 3 or 4 times before doing the pap smear, because that's how long it took to feel comfortable. And we're happy to do that with people. That's not the care that you get universally, and that's very upsetting because it should be. So I'm going to stop because I kind of got lost in my ranting, and we can either like answer some more questions from the group or we'll go on to our next question.
Well, I just wanted to pull out, there's been a little bit of a conversation in the chat about gender affirming care for young people, both those who are minors and those who are young adults. And I just wanted to toss that over to Aspen if you wanted to pull some of that out in the chat and address it. I think it's important.
I absolutely do. I think, and this, I don't know who can see the chat and who can't see the chat, but folks, so when I mentioned, you know, I did specifically talk about people who are like legal adults, because like that's who we're able to see right now for gender affirming hormone therapy, because legal stuff. And it's very frustrating. And I mentioned this in the chat. So 2 things when it comes to young people and gender affirming care. So the first is puberty blockers. A lot of people have heard of them. A lot of people haven't heard from them. Puberty blockers are a medicine that's basically just a pause button on puberty. It's just like, ooh, let's take a break on this for a second to figure some things out. Now, we most often think of puberty blockers for trans kids. And when they're in the context of being for trans kids, they get treated as this big, scary, dangerous thing, even though they're not. Here's the thing. We've been using puberty blockers for cis kids for like a while. So, you know, cis kids who aren't trans, who go through what's called precocious puberty, which is the medical term. Like, you know how puberty just hits some people real early and like, you know, they're still a little kid and like it maybe might not be ideal for them to go through puberty yet. That's who puberty blockers were invented for. And like when those kids use puberty blockers, it's seen as a perfectly normal and safe thing to do. And then all of a sudden, when it's for trans kids, people start wringing their hands. So that's a problem. And that clearly goes hand in hand what I was talking with before about like trans people are not seen as being capable of having a say in their healthcare. And that's a problem. But then also young people and taking hormones. Like obviously no one's giving like testosterone or estradiol to a 12-year-old because like that would be the really early stages of puberty anyways. But like, you know, most often like trans kids who like it would make sense to consider hormones for, if that's something called Good Girls on Netflix to look into this. I should probably check that out. I mentioned in the chat that, and you know, in my case, so I am someone who's non-binary, genderqueer, you know, a few different labels out there that I like, because, you know, labels are just adjectives. And, you know, I didn't really start figuring out my gender stuff until I was like between 18 and 20. And I am someone who does use testosterone. That's a more like recent development in my life. But when I was 16, freshly 16, like a month after turning 16, I was able to go on hormonal birth control without parental permission. Now, my mom did know. She set up the appointment for me. We have a good relationship, but I could have done that and accessed it really without having to get permission from her. And you know, she like, I was told about side effects, but this was treated as like a really normal thing to access because hormonal birth control is a normal thing. Even though hormonal birth control has way more concerning side effects than gender affirming hormone therapy does. And like gender affirming hormone therapy has way more like attention paid to the side effects, because like if you're on hormone therapy, like you're getting blood tests done to make sure they're not giving you too much and to make sure like that everything's all good. When it comes to hormonal birth control, it's like, all right, take this, good luck. Let's hope we don't put you on a medication that's contraindicated. That has happened to me, which was a very fun and scary time to realize. So like, obviously we like, minors are people. A lot of the time youth are still learning the rules of being a people, but they're people. And they should have control over their healthcare and their bodies. And that is true whether we are talking about accessing birth control or accessing abortion care or accessing prenatal care if they're pregnant and they want to continue a pregnancy, or accessing hormone therapy. All medical care has risk attached to it. All existing as a human has risk attached to it. That's the human condition. And it is definitely a huge frustration for me, the barriers that we run into when it comes to really everything around trans youth. There's this attitude that like, oh, they don't know enough to know who they are. And it's like, if cis kids know who they are, we're not making cis kids go on puberty blockers in case they change their mind. So we shouldn't block trans kids from gender affirming care for the same reason. I don't know if anyone else wants to take up after that, but.
Yeah, I mean, I just want to, the heart of all of this type of care is about bodily autonomy. And, to Shauna's point earlier, like we have gotten used to these types of care we're talking about being very siloed from general health care. But, our sexual and reproductive health and well-being impacts our mental health and well-being and impacts our entire lives. And so, just to say that while like Aspen says, every medication, every, medical intervention we make has potential risks and benefits, what we know is that having a home where a trans child is affirmed in their identity and their gender and gets to make choices about what that means for them, that dramatically reduces risks of mental health issues that are very negative, right? Like we know right there that it lowers rates of suicidality enormously. In fact, all of the sort of negative health outcomes that plague trans folks in the United States are really because of transphobia. And so when we give people safe homes and safe access to care, we see those risks really almost disappear. And so, thinking about being a parent of young people, if people are parents, to consider, the risks. It's not a hard thing to want to support a child when you consider the alternative of not offering that support and care could mean losing one's child, right? And that's just something we can avoid so easily. So with all the talk about risk, we have to really consider, we have to be critical, I think, about when we talk about risk. And I think that relates to risks associated with using substances during pregnancy. A lot of these things there's hype in the media that's not really based in research, and it's not based in how people really live their lives. And so we just have to always be critical when people talk about risk.
I think reframing that and focusing it on what Kate was saying about having that support system, the way that your family surrounds you in love and acceptance while you're figuring out the thing, if that makes sense.
That absolutely makes sense. And so first, to touch on the being too young to know or like not too young to know, I want to touch on that first, which I touched on it a little bit already, but we fully accept that like cis and straight kids know who they are and know that they are those things. But then when it comes to LGBTQ plus kids, then all of a sudden that's like, oh, you're too young to know your identity. Why is someone too young to know that they are a lesbian, but they are not too young to know that they are straight? Why is someone too young to know that they are trans, but they're not too young to know that they are cis? And it's because being part of the LGBT community is still framed as being abnormal and outside the norm, while being straight, while being cis is seen as the default. So it's not that it's like the reason that like we say a 4-year-old can know that they are straight, they, you know, which is like also just weird stuff about how like we put like, oh, he has a crush on her, and it's like they're 4, calm down. But you know, like, is because it's not that we're viewing like, oh yeah, people are all different kinds of things. It's that this thing is normal and anything outside of it is an aberration. So we have to break from that mindset first and foremost. It's something I've certainly run into, because also that mindset has the other side of the coin, where if you come out too late, then it's, oh, well, if you were actually that, you would have known when you were young. So you just can't win. You know, like you just can't. But so like an example I have like that I know in my real life, someone who, a family member of mine who like, you know, is a lesbian, and at like age 10, this is, like I said, a family member, you know, was like, came to me, was like, yeah, I like girls, I only like girls. And I'm like, cool. And I like talked with my mom about it, and she was like, well, she's too young to know that she likes girls. And I'm like, did you think I was too young to know I liked boys when I was that age? And she was like, no. And I'm like, then why is she too young to know she likes girls? And she didn't really have an answer for me. And also a thing we've made progress on. But so to get to the like you mentioned, supporting, so often, particularly when it comes to gender stuff and people being trans, I mean, sometimes it comes up around people being a lesbian or being gay or being bi, but particularly with gender, you know, people will be like, well, what if it's a phase? First off, everything is a phase. There's no such thing as the permanent state of the self. We're all always changing. But more importantly, if it is a phase, then what you do is you still support them, because you won't know whether or not it is. So if, let's say, someone who I care about, who, let's say they're young, I'm going to make up an imaginary cousin. I'm going to pretend I have a 12-year-old cousin who comes to me and is like, actually, I'm not a boy, I'm a girl, I'm a trans girl. If I support her, if I support this child and say, I see you as you are, I love you, I care about you, and I'm going to call you the name you want me to call you, and I'm going to call you the pronouns you want me to call you. Let's say sometime down the road, this cousin's like, actually, I realized I'm not a girl. I actually am a boy. I want to go back to my old name. Then we go back to the old name. And in that case, it was a phase. In most cases, it's not. On the rare occasion when it is, I have shown that person in my life that they can trust me, that I will love them unconditionally, and that I will support them. Let's say, again, same situation where it turns out it was a phase. It turns out that they actually weren't trans, which again, most often if people are exploring their gender, it's because they're not cis. But again, let's say this is a phase. They come to me and I don't support them. And I say, no, I won't use the name you want me to use. No, I won't use the pronouns. No, I will not respect you as you are asking me to respect you. Then when they end up being like, oh, actually, it turns out, again, I am a boy, I'm actually not a girl, you know, I'm not trans. That's not really like a, oh, I'm so glad that person who I cared about didn't support me. That's like, wow, this person didn't support me and I didn't have that support. And honestly, having that support would probably help them figure out sooner if it turns out that they really aren't trans. So there is, not only is there no harm in providing that support, there are so many benefits, because again, if it turns out that they're actually like, psych, I guess I'm not trans, what you have done is shown that you are a loving and trustworthy person, and that you actually care about them as a person. Because again, if it turns out that they were wrong, it's not like they're going to be like, oh gee, I'm so happy Aspen was really mean to me about that. Like, that's not going to be the response.
I have a question that I have many questions and thoughts that I want to share, but just kind of responding to that point, Aspen, it brings me back to thinking about healthcare provision. Importantly, that has come up many times in this conversation, and thinking about the model that Mabel Wadsworth is offering, and how we educate our healthcare providers. The difference between sort of some of the traditional medical education and something, for example, like a midwifery philosophy of care, and how we can apply that type of philosophy of being with each other, educating, supporting, and being present with each other. How we can apply that in all of these realms, whether it's birth or abortion access, contraception access, trans care. I'm particularly interested in how we can take that model, maybe that Mabel Wadsworth sounds like very successfully doing in Bangor, and extend it to some of these other regions, like Piscataquis County, where I'm hearing that Maine Family Planning, for example, that has, I believe you said something like 18 clinics around the state. I don't think any of them exist in Piscataquis County.
No.
And I'm super concerned about that that lack of access in general. Because one of the big barriers here is there are no services, right? But just coming back to that opportunity to educate and take some of this research that maybe some of the providers at a place like Mabel Wadsworth are very present and up to date on in terms of gender-based research, and share that with some of the local providers here. That's just kind of one of the things, or many of the things that I'm thinking about, and wondering what ideas you all might have about how we can extend those services to this region. And this is coming from, I'm somebody that's from away. I did not grow up in Maine. I moved to this area about 7.5 years ago. I've lived and studied in places like Philadelphia and New York and California, and so many of the local norms and discussions that come up here are even new and surprisingly challenging in my experience in life. So just trying to be a person who can reflect the present needs, and maybe provide some bridge of support in some way for more information, for normalizing these conversations that are about very real topics. So that's all I'll say, and then just pass it on to you all again. Thank you so much for this.
Yeah.
Hey there. I'm Kristen Wagner. I'm one of the providers at Mayo Regional. So I am a family practice provider in our community, and I also provide obstetric services. I work with Dr. Kirsten Sutton to do that. And I can speak only for myself, but after having conversations with some of the other providers, we're very interested in supporting women, people in general, with reproductive issues and gender issues. A lot of it has to do with timing. You know, I know that the people that ask for hormonal replacement therapy or any of those things that are more complex. I'm sorry, I'm using the improper terminology because it shows my lack of knowledge, I guess. This wasn't a thing that was gone over in my residency.
Kristen, I think we've lost you. You've frozen on us, and I hope you come back. Jump in, please, if you can. I'm so grateful that you're here and that you came across this opportunity to talk to each other, and I think you're in safe and good company. I know I've already made some mistakes in language myself, and I'll say I just appreciate your courage in jumping into the conversation.
And, you know, to what you were saying, you know, asking about, Tara, I think, yeah, there certainly were several clinics that were family planning clinics in Piscataquis County that over the last 12 years or so have closed down. So we know there's like a budgetary issue, right? It costs a lot of money to run a clinic in a rural area where you don't have a high volume of patients. So what that means to me is, I mean, I think people want to have clinics there, and also there isn't the volume that would make that brick and mortar clinic something that was really fiscally feasible. But what that says to me is that in rural communities, it feels more and more important, I think, for patients to sort of push on the providers who are there to say, like, we need you to be comfortable doing, for example, contraceptive counseling. We need you to like get up to date on that. How do we make that happen? I think that's a whole community issue because it does take like resources for people to get training that they don't already have, or, you know, like Kristen was saying, like if HRT, hormone replacement therapy, was not part of someone's like education as a provider, like, well, that's true for many people. So I want to say Maine Family Planning, the nurse practitioners there, they were sent to do trainings to become trans competent as providers, and they were sent to Fenway Health in Boston. Now, of course, that takes resources to do that. So this is a question of resources and how we prioritize that ongoing learning for care providers, because we may not get the clinics, the brick and mortar services in Piscataquis County right away. But what can we demand of providers locally, and how can we, you know, how can communities come forward and say, this is what we need? How do we make it possible, right? And I think that's also on the state legislature to make more resources available so that we can have gender affirming, competent, trauma-informed care, sexual and reproductive health care in all counties equitably, right? And so I think as individuals, we can ask providers, right? Because there are a lot of primary care providers, for example, who never talk about sexual reproductive health with their clients. They just expect that people go elsewhere for that, or they don't talk about it and wait for a patient to bring it up. That's really uncomfortable, you know? And so I think that's just really important for us to keep pushing for the things that we deserve, right? And to push for the resources to make that possible.
Thank you so much, Kate. Kristen, do we have you back?
Yes.
Wonderful. I just wanted to invite you to respond to some of the things Kate said and continue what you were sharing with us.
Yeah, sorry. As I said, I'm on leave, and when I started listening, I was nursing my baby, and now I'm trying to get dinner for the kids. Just picking up Chinese food, let's just be honest. So I think the community encouraging the facilities to send us for training would be great. All of these things as providers we would like to do. So it's going to take administration allowing that to move forward and seeing the need for it. So that's going to be the advocacy, because there's only so much as providers they allow us to do. And not that they don't we are not allowed to do surgical abortions at Mayo Regional Hospital. It's part of the bylaws of the hospital. But medical ones we can. Very few people, thank you, ask for that. So that's something, but I will say that there are a lot of providers in the community who won't talk about STIs with their patients. You know, I do many well woman exams that are just very traditional and boring because their providers won't even talk about that. And so I would say that myself and one other, there's 3 of us that are newer from residency, and we get a lot of those from some of the older providers that just, they won't take care of anybody naked, you know, or any of those issues. And it's not that they're just not comfortable, and I don't know that that's going to change, but like having the people who are comfortable having more complicated conversations that are willing to learn and grow and do other things, to be supported to do that would be great, you know. So
yeah, and I think that there's, even if someone cannot provide a certain type of care, I think for providers to get educated about what are the resources in the state. And then there's like, you know, like, how do you do warm handoffs to get people there? And for a lot of people, it's even just the, you know, removing stigma and gender from the language that we use, that makes a big difference to someone. If they go to a rural, you know, provider who doesn't assume their pronouns and asks what name they'd like to be called, or, you know, someone goes in for a pelvic exam and they're trans and they, you know, things aren't being assumed about them, and just a conversation about like, are there words for your body parts that you prefer that are different than the ones that I might typically use around your anatomy? Like, can we talk about that? I mean, those are things that make an enormous difference. And then I think there's a community care component of this where, you know, people getting together in the community and saying, okay, this care isn't available for us here, but we want to get people who need it where they need to be. Can we set up a driver, like a volunteer driver sort of tree or a phone tree, so people who need help getting rides places know that there's a group of people who are like, if it works for my schedule, I'm going to help you get there. You know, but there are really small changes we can make in our language and in our approach that show people like, I'm trying with the limited resources I have to give you the best care I can. And so that kind of like self-education is, you know, always available, right? And there are lots of folks in Maine who'd be happy to share the knowledge they have with providers who want to know it.
that's great. And I appreciate you guys starting this conversation, you know, and being a resource for the community.
Thank you for jumping on, Kristen, and for speaking up. I'm glad that you're a provider here in our region. Makes me hopeful. I just wanted to share some of the things that are coming into the chat too. Trisha Smith just wrote, I just left Mayo for Mabel's. I had no idea someone could get medication and abortions at Mayo. That's, you know, I think a really important point. Trisha, do you want to speak on that, add a little color to that comment?
Sure. I mean, I've needed abortions several times in my life, and I've always, well, the first time I needed one, I was living in Seattle, and so it was super accessible. But the other times I've needed them, I've lived in rural areas and had to travel, like, and be there overnight, and they're expensive. Being able to get it in my hometown, I had no idea I mean, and actually it wasn't available at the time I needed it, but that's so important to know that your hometown hospital has got your back. I cannot believe they are not like shouting that from the rooftops that we can do fucking abortions. We can mail the pills to you and and you'll be done in like, what is it? 48 hours? Like, why are they, it's ridiculous. Come on now.
Thanks.
If you have great service, you have a great service that's available to people at your hospital, why are you not making sure everybody knows about it? What is wrong with you?
Thank you, Tricia, for shouting that on behalf of Mayo. And it makes me think back to Abby, the options that you were describing that are available at family planning and Mabel too, I believe, about how in any of the clinics that, even if it's a mid-level provider, right, that, you can get on a telehealth call. And if you could share a little bit about how that process works, maybe for the public, that would be wonderful.
Yeah, I also just want to add that I'm really excited to hear that they offer medication abortion at Mayo, and I try to know these things about the state of Maine, and I wasn't aware either. So I'm really happy to have learned that tonight. So I can talk about accessibility at Mabel's, and Kate might be better to speak to Maine Family Planning, and so right now at Mabel's, we offer the in-clinic procedure and we offer medication abortion, but folks do have to come into our clinic currently to access medication abortion. But we have additional services that we can offer via telehealth, including like an options visit if you wanted to talk about if someone was unsure, if they were pregnant and unsure of what they wanted to do, something like that we can do via telehealth. But currently, folks do have to come to our clinic to pick up the medication abortion. I don't know, Kate, could you speak at all to Maine Family Planning Services and how that process works?
Yeah, so folks it's called the Meds by Mail program at Maine Family Planning. So if someone were to call and say, I need to, make an appointment for an abortion, they would offer all of the different ways that could happen, including coming into the clinic to get the medications, including an in-clinic procedure in Augusta, or they would talk through the Meds by Mail, which is a combination of a telehealth visit with a provider to make sure that person is giving informed consent, get all their questions answered, and then the medication would be mailed to them. And so it's important to know with medication abortions that even if someone goes into a clinic or a hospital like Mayo to get one, they're going to take the first medication there, but they're going to pass the pregnancy wherever they are later. And so it really is, it does require a level of sort of self-managing. But when you do that with a clinic, it means they always give you a number so that you can call them 24/7 if you have any questions about what's happening, bleeding and cramping, and is this normal? So, that ability to combine telehealth, which can be done on a smartphone or, a computer, whatever, and mailing medications is a good option for some people, right? But it's really like, we don't have truly meaningful abortion access until we have really good access to the in-clinic option or the aspiration procedure, because medication abortion is really only available up to 10 or 11 weeks. And a lot of people are not finding out they're pregnant until about then. Some people aren't knowing then. So then we really need to, it's a wonderful option, but for someone who is beyond that 10 or 11 week period, they need to potentially drive quite far, depending on where they live. If they're in Aroostook County, all the way to Bangor and to Mabel's is a long, long way, right? So, yeah, we need all the options, right? We want everything. And I see Tricia saying in the chat that best abortion I ever had was at Mabel's. So I hear really just the care providers at Mabel's, the staff at Mabel's are incredible. So
I also just wanted to add that there's like, I want to emphasize the importance of access to the in-clinic abortion, and that there's a new service for for many states across the country to be able to access the medication abortion online through a website called abortionondemand.org. And that is really changing the landscape. I think my understanding, it's only abortions up to 8 weeks. So it's even earlier than what you would be able to access. Like if you're going to a clinic, you can get medication abortion up to 10 or 11 weeks, as Kate said. So it's for very early abortion, but it's going to change the landscape of access to medication abortion across the country. Of course, it's not available in all states because of the restrictive laws that many of the states have that I mentioned earlier tonight. But again, like Kate mentioned, it's really important that people have all options, because you can have either a medication abortion or an in-clinic procedure. Like when I was first learning about abortion, I thought, oh, if you're under 8 weeks, you have to do the med. And if you're over, you can do the in-clinic procedure, but you have the choice. And it's important that people are able to make the choice on what is going to be the best experience for them. And there's a wide range of reasons why someone might choose the medication versus the in-clinic procedure. And both experiences, one experience could be really positive for someone and someone else could have a really negative experience with that. And that's why it's so critical that we can make those choices for ourselves and not be based on what is available to us, right? And then I also just wanted to lift up the work that Kate's doing, because when we're talking about what kind of care we have access to currently, and Kate's really bridging that work of being an additional support person in those spaces that maybe aren't providing the care we wish they were. And we can all be part of that work of bringing what we want to our community, and we don't have to be doctors and or nurse practitioners to be part of that work. And even at Mabel's, one of our founders was a healthcare provider, but most of our founders were not. But they saw this need of really this, it was called Health in Our Hands in the 70s, of us being able to control our healthcare. And they had that vision, and they were visionaries and worked with our community to build it. And that can really be built in other spaces as well. And I think like I was saying, I think Kate is doing that work. And there's room for all of us to participate. So just wanted to add that.
Yeah, and I know we're getting close to the end here, but thanks for that, Abby. I think the message that feels really important to me to get as far spread as possible is that ordinary people without clinical training can do a great deal to reduce the potential harms of these systems. And, you know, there are good people in bad systems. We know that, but they are, you know, usually forced to enforce these policies that can be harmful, or they're part of a culture that is harmful, and maybe not even intentionally harmful, right? So ordinary people, that's what doulas are. Doulas are ordinary people who we're not clinically trained. We're there to make sure that advocacy can happen, so someone can have birth on their terms. We're meant to be there to focus on the birthing person when most hospitals are really focused on the baby. And to, you know, to be an extra layer of support and clarification, and ordinary people can do that in so many ways. And I want to lift up something, and Shauna, maybe you can share this on the Facebook too, but just thinking about what can ordinary people do. We've seen, you know, ordinary people in Maine create a volunteer driver network, for example, to get people to abortion appointments, because so many people have to travel far. This is an example that I'm putting in the chat. It's called the Family Justice Group. We're actually meeting right after this, but this is a group of directly impacted mothers who have had some engagement with the family policing system. And they're coming together to create a space of solidarity and peer support, and then activism to change the policies that are harming their families. And that's really disproportionately poor and Black and Brown families in Maine. The racial disparities, the class disparities, and the geographical disparities, our rural communities are having families taken apart at far greater rates than our sort of urban communities here in Maine. Our rural counties like Piscataquis are disproportionately affected. And so that's an example of people coming together and saying, let's do peer support, let's help each other out. And what I'm hoping to do is make childbirth education free to poor people in Maine. It's also something I'm hoping to people who can pay for it to pay for it, but to really make sure that poor folks know that they have rights, that they are doing their very best with whatever they've got, and that when we remove judgment and shame and stigma from our reproductive experiences, it's not just birthing people who thrive, but children thrive as well. And so I just want to name that ordinary people, especially in rural communities, I think have ways of coming together and saying, look, we're all we've got. So, we can't suddenly make more and more, doctors come here or nurse midwives want to come here. We can't do that overnight. So what do we do in the meantime? And trans folks have always shared information with each other about hormones and how to transition and how to be in one's gender identity well before there was broader access to this medical care, right? So we've always found ways to do it. People trained themselves how to do abortions when it was illegal and perform them because people needed abortions, right? And so ordinary folks really make the world go round, and there are so many more of us than anything else. And so I just feel really inspired by what regular folks do to take care of each other. That's really the whole message for me of all of this.
Thank you so much, Kate, and everybody for all of your words. I want to invite everyone to share some closing thoughts. We are at time. I'm willing to keep this conversation going and even go off Facebook if anybody wants to, but just putting an invitation out there for everyone to share any closing thoughts they might have.
I think going off of what Kate said, that so much of, accessing, getting the care we deserve is what we can really do as ordinary people. And I think that when it comes to because obviously my biggest focus is usually gender affirming care for trans people. And that's true there as well. A lot of people think, oh, well, it's hormones. And unless someone's getting illegal secret hormones, which yeah, there is a market for black market hormones because the accessing of them can be so tricky. It's not so much here. It's more in other places. But supporting as a normal person, it can, I was saying, just about someone you care about comes out as trans and just being cool about it. That is, as Kate was saying, that's life-saving care, you are providing life-saving care in that moment. Obviously there's helping give rides and things like that, which is really important, but a lot of it is also just not being another source of stigma and shame, and instead being a source of care and support.
I just think that's a great place to wrap up tonight. And so I just want to say thank you all. And I was really glad to be a part of this conversation tonight. So thank you for hosting us and for all the great questions and dialogue.
Yeah, thank you all so much. And I can't wait to come up to the Dover Foxcroft again real soon and see some folks in person and maybe do a childbirth ed class up there. So thanks for having us. I just love the work that Central Hall Commons is doing, and I've loved the community that I see in Dover Foxcroft whenever I've been there. So really appreciative.
Thank you so much for joining, for being a part of this conversation and making this happen. I'm really excited to continue it.
I gotta say, this was super gratifying to see you folks all on here together. It's really cool. And I love Piscataquis County, and I love to see it lifted up. So thanks.